Hey, Fit, sit down.
Good morning. I would like to call to order the Joint Subcommittee on Human Services. Secretary, please call the roll.
Senators Canizaro, Dondero Loop. Here. Stone. Titus. Wynn. Assembly members Brown May. Dickman. Hathan. Hibbets. Hadigi. Monroe Moreno. Yeager. And Chair Mosca.
I am here. Thank you so much. And if you can please mark Majority Leader Canizaro here as she arrives, as well as Assembly Member Monroe Moreno absent excused. Well, it's great to see everybody, and thank you for everybody that was here last night. We appreciate you. I would like to remind everyone to please silence their cell phones and electronic devices. Public comment will be available at the end of the meeting after budget presentations. I would like to open the budget hearings for the Department of Health and Human Services Director's Office. There are 5 budgets on the agenda today that will be heard, including the Director's Office Administration Account, the Fund for Resilient Nevada, the Grants Management Unit, Individual with Disabilities Education Part C, and the Nevada Health Authority DO Data Analysis. We will begin the hearing with the Director's Office Administration Account. Thank you. And please state your name for the record, and please remember to restate your name anytime you begin speaking. Please begin when you are ready.
Thank you, Madam Chair. For the record, Richard Whitley. I serve as the Director for the Department of Health and Human Services. And with me to my right is Stacy Week. She serves as the Administrator for the Division of Healthcare Finance and Policy. And on my left is Shannon Litz. She serves as my Deputy Director in DHHS. And correct me if I have this wrong, but in following the agenda, we were going to first do an overview of the reorganization proposal.
Yes, go ahead. Thank you.
All right.
Madam Chair, Stacy Weeks for the record. Good morning. Thank you for having us at 8 a.m. this morning. It's good to see you all again. So like as Director Whitley was mentioning, we'll start first with the agency reorganization. I think we have a slide deck, so we'll start with that. And I think it's the second slide, so hopefully that's up. Oh, it is up, sorry. Okay. So as we talked about before, the goal of the reorganization is to really align priorities and increase efficiencies and enhance our state's purchasing power through this agency reorganization. As you all know, the DHHS is a very large, complex agency. It serves as a provider. It also serves as a regulator. It also serves as a payer, and in many ways a consumer resource to the state. So it plays many roles, and some of them have their own conflicts inherent in that, right? So a provider being its own regulator, things like that. So one of the things that we are looking at is really proposing a reorganization of this department to better align efforts, remove any conflicts, and really streamline services. So as you can see in the visual, it's DHHS, and then it breaks out into 2 entities. There's Nevada Health Authority, and Department of Human Services. And so Director Whitley will walk through, after I walk through the Nevada Health Authority, he'll walk through the Department of Human Services. But the goal of the Nevada Health Authority is to really bring together all of the state's coverage programs in a manner to better support those programs, hopefully leverage a greater purchasing authority and power similar to a large employer. So we're bringing in the state Silver Health Insurance Exchange, that's the SHIX bubble there on the right, and the Public Employee Benefit Program. Next slide, please. So many of you have asked, why are we doing this? What is the need? That's a great question. So when we look at healthcare in Nevada, we have an 8.9% annual growth rate in cost. It is actually the highest in the country when it comes to healthcare cost and inflation. So it's something to think about. And as we look at Nevada's budget and our state revenues, and I think we're very proud to say that we don't raise taxes and we don't have a lot of taxes, I think keeping up with the cost of healthcare with Medicaid covering 1 in 4 people is going to be challenging. So we have to look at how we're doing that differently. Same with our state employees, right? So we also are the largest spend for state general fund. About $2.7 billion this biennium is projected. It will be on Medicaid. The state covers 1 in 3 Nevadans across all these. When we combine these programs, we will be covering or supporting coverage for 1 in 3 Nevadans. We also are looking at ways to really control and help bring more competition to the state employee health plan. As you may all know, it is not a very competitive market as it stands today. And state employees, and I'm on that board, so I feel like I can say this, and I know I think Celeste Glover is here in the audience today as well, but it is a challenge to control those costs, to keep premiums low, and to provide quality benefits to our state employees. And I think that is one of the things we need in this state to really attract the workforce that we need. So that's something that is part of this effort. Also, another reason is that our county, every county in this state has a health professional shortage area under federal law. That is significant when we think about the need to actually provide access. As Director Whitley has said many times, having health insurance isn't health care if you cannot get access to a provider in a timely manner. So also part of this new health authority is really looking at GME efforts, looking at ways to leverage Medicaid when we're able to under federal law to really bolster those efforts, but looking at training programs, other ways to really build our workforce. It also brings in, and we'll talk about this in a minute, our licensing agency. One of the reasons we want to align that with our efforts with Medicaid is so when we're bringing someone in, we're really developing that workforce and that facility workforce so we can get them enrolled in Medicaid and start providing services. So it's really trying to streamline that process and provide a one-stop shop for providers coming into the state. We also have limited provider networks for state employees, and we rank, as I've said before, in the bottom 10 in most healthcare rankings nationally. We have to do something different, and that is what you have before you as a proposal to try to do something different. Here on the right in this box, and I will just recognize that before you, all you have is the budget. There is a budget BDR that has been drafted. I know that will be coming soon for you to see that really outlines like you would see in statute today for DHHS, right? It really establishes the authority, what is the duties and roles, who are the director, the deputies, all of those things that you see in statute for DHHS today. So I just want to acknowledge that there's more, and that's why we wanted to put some of that here today so you have it. As you can see on the right, that is the mission of really developing that sufficient provider workforce, securing affordable coverage, supporting more effective, efficient, and responsive healthcare systems in our state, and ensuring truly the long-term sustainability of these programs. And that really requires us to minimize the state financial burden, but also on Nevadans and our public employees. We do that in 3 real ways. Under the new entity, it's really aligning cross-market cost containment measures and looking at federal resource maximization and innovative state purchasing and contracting strategies that we are not currently doing today as we're currently designed in the state. Next slide, please. This is a proposed organization chart. It is part of the budget proposal, but I wanted to put it on the slide so we can kind of walk through it so you have a sense of how things are grouped in the new agency. So to really leverage the Medicaid funds and to really prioritize and align efforts, I mean, if we're covering one in 4 Nevadans in Medicaid, addressing access and addressing other issues really is, in these other programs, is supporting Medicaid too. We're all doing, in many ways, the same thing. We're trying to get better access and better coverage. So the director would maintain the title, the state Medicaid director. This is the same in some other states. The state Medicaid director is over a larger body of work because it is aligned. There's also going to be obviously a chief of staff and operations, chief IT enterprise officer, and obviously our office of analytics, like Director Whitley has mentioned, will be coming over into this new entity. And then at the bottom here, you'll see 5 buckets of real priorities. The first one on the left will be new to the state in many ways. It's a healthcare purchasing and compliance entity. It's really driving, and that shouldn't say general counsel, should say regulatory counsel. We really need some of that in-house legal regulatory expertise to support Medicaid and healthcare. It's very complex. There are a lot of regulations, a lot of rules, and also when it comes to purchasing, this new entity will have its own state purchasing authority when it comes to health coverage programs. It'll have also the licensing unit will be here under compliance and workforce, as well as we're taking our fraud, waste, and abuse unit, which we call SIR, over into this unit and from Medicaid, and it really will be focused under like an Office of Inspector General. We really need this work to be independent. We need it to be prioritized, and right now it really is sort of an element of Medicaid, but it's part of a larger program, and this really will elevate that effort. I will say fraud, waste, and abuse on our provider side is a problem, and it is a challenge, and we need more support and focus on this work. It is significant savings when we do find fraud, and we work very closely with our AG's office on this effort. The second bucket is healthcare financing and budget. This is an area that right now primarily lives in Nevada Medicaid. We're bringing that out to be part of the larger department. Where can we leverage federal resources that we're not leveraging them today? Other states do that, and they match employees that are doing the efforts that are supporting Medicaid. And that's what this would be doing. But it also would be putting in most of the other budgets except for PEB and the exchange, as well as HCQC, would not be part of that because those would not be technically matchable at this time. And again, like I mentioned, most of this lives under Medicaid today. So when we walk through our budget in HHS for DHCFP, there are enhancement units that are related to this because we're leveraging our budget account that we have today for staff and administration. The third bucket is what we consider today as DHCFP. That's Nevada Medicaid. It will be renamed Nevada Medicaid. We need things to be translatable to the public. DHCFP is not. When people Google Nevada Medicaid, they don't find our website. We need to be very clear about our name, so we're renaming it as Nevada Medicaid because that is what it is. We will have our benefits unit like we do today in this unit, our delivery system, which is our managed care and fee-for-service system with our fiscal agent who pays our providers on the fee-for-service side. We still have our hearings unit here, our federal waivers, and long-term care services. So it's really kind of relieving some of the pressure on this side and letting it be the program side. And then the next piece here is consumer health and access. There are a lot of different efforts going on, and you can see them in this bucket. Some of them are being proposed in the budget, including or proposed by the governor. We'll be moving the state exchange over in this bucket, the Medicaid Express, which is in our enhancement for our budget at DHCFP. This is really trying to get enrollment and eligibility into our exchange to remove any stigma that may unintentionally exist in the current system, to make it real time and easy. Right now it is complicated for people sometimes to enroll, and so we're trying to remove any barriers, so it is a simple process. And we have the other nice thing about having this through the exchange is that people can shop for their plans. They can actually compare their networks. We can do quality rankings, so we can actually educate, like any other consumer, our Medicaid recipients, so they can pick and choose their products, just like anyone else. This also includes the Office of Mental Health. Right now, that is in the healthcare policy bill. There are two bills related kind of to this effort. There is the budget BDR I mentioned earlier, which is the Nevada Health Authority and DHS reorg. And then, as you know, the governor mentioned a healthcare policy bill. The Office of Mental Health is in that bill. So I just wanted to recognize that it's separate from some of the work in our budget. We also are bringing over today the Patient Protection Commission currently reports to Medicaid. We would be bringing that over into this new Consumer Health and Access Unit, as well as the Public Option and GME efforts, really trying to leverage GME, leverage Medicaid, and really try to get that program broader statewide, and working with our universities in doing that. Last but not least is our Public Employee Benefits Plan. This would be moving over. We're doing our best not to create any disruption, so as it is today, we're trying to maintain its current structure. But as we begin to work together and really develop that implementation plan where we can leverage the director's office resources to better support public employee benefit plan, that's what our goal is. And also we will be leveraging our clinicians. We have a pharmacist at Medicaid. PEB does not. And so we could actually be using some of those resources to support them, as well as our medical director and our dental officer. So there's a lot of efforts here that can be more efficient and effective across programs. Next slide, please. All All right, so I just wanted to make sure everyone was kind of clear on that slide. So in addition to PEB and Exchange coming under with Medicaid together, there are other programs within DHHS that are also moving over. Like I mentioned, the PPC, Office of Analytics, which I just want to note, Office of Analytics would still be supporting a lot of the efforts at DHS. This would not just be supporting us. We would want it to be a state resource. So I just want to be clear on that. Indigent Hospital Care Fund, this currently is a Medicaid fund. It is just right now managed out of Director Whitley's office. It makes sense to bring it to Medicaid regardless of this restructure, so it is coming over. DBPH's Healthcare Quality and Compliance Unit, like I mentioned, as well as a deputy administrator with that unit, that is coming over. ADSD also has Medicaid provider oversight and audit and review teams. We are bringing that over into the new Medicaid Inspector General office to really make sure we are providing oversight, because ADSD is more of a provider, and it is very challenging when you are the regulator and the provider under one roof. So we're trying to provide that independence here. And the last but not least is the Governor's Council on Developmental Disabilities. This currently is under the Director's Office at DHHS, and it'll be moving over. We're proposing to move it over and to really provide more insight and oversight for us, because we do fund a lot of these services, and to help us understand if providers and the program is not working for individuals with developmental disabilities. Next slide, please. Okay. This will be the most boring slide, I hope, for the day. It's just a list here of kind of how we've broken it out. So I would just point you to the left side here. 410 is our agency number for most of Nevada Health Authority. We're trying to make this streamlined, simple, and so we can really leverage and maximize federal resources across the department. And then 412 is what is HCQC. Because it is a fee-based program and the way the fees work, we want to make sure that that account and those fundings are separate to the extent they need to be. And so if we would be leveraging Medicaid funds for that effort at any point, we would have to do a cost allocation plan like we do today. At this point, it is separate. 415 is the Silver State Health Exchange. We are keeping that separate. It is a separate, unique budget. It collects fees on carriers and self-funds itself, so it makes sense that it would have a separate budget account and agency number. And 416, same with PEB. It is a different structure and funding. And under here, as you can see, we've listed all of the accounts that are coming over for your. So hopefully it's a little easier. There, like I mentioned, there are enhancement units in our DHCF budget that are really providing several new staff for the director's office and to support these new units that are being built under the new structure. And with that, I will turn it over to Director Whitley.
For the record, Richard Whitley, I'll speak to the other side, the Department of Human Services, just briefly. What stays intact are the divisions as they are now, and you'll hear each of their budget presentations as we go forward. But we've tried this approach to reorganizing multiple times over the years, mostly focused on the direct service side. And so, interesting this time, the most momentum we have and the and really before you today with presenting something that we hope will be supported is on the purchasing side, and the also just because I was pushing the healthcare quality and compliance as belonging at CMS. It's combined, the payer and the regulator. It's also to as any of you that work in healthcare or know people who do, the delay in getting, you have to be licensed to get certified, and you can only bill Medicare and Medicaid if you're certified. Same people do all things. So as we have people coming into our state wanting to stand up more health care, especially facility-based, it's hard. And so I think there's benefit in that when we looked at other states. We also never looked this long and this deeply in at how to do this. We might get some wrong. It may be incremental policy making going forward where we identify other components that belong. But we think that the core pieces are there. Depending on what happens at a federal level, there may be opportunity. We looked at public health. I think originally in the Affordable Care Act, there was intention to have preventive health be a part of health care, but it federally never happened. You still, much like us, but probably worse, with bureaucracy, CDC and HRSA and CMS, and, a lot of things are funded in the same place or activities. And so if things change at a federal level, there makes sense to in another session to look at other pieces that more appropriately belong in the health authority. On the human service side, though, there's been discussions in IFC. There's been we're getting penalized for delays in adult mental health for forensic services. This will give us an opportunity to really focus on population services and the state's role. And if you just bear with me, there is a longer-term plan here in terms of opportunity. I tried during the pandemic to be helpful to Department of Corrections with medical services, and our building blocks are so fundamentally different, hard to work with. But there's a common denominator with the Veterans Nursing Home in Las Vegas. It's a skilled nursing facility provided by state staff. Our hospitals, we have both adult and children, and then Department of Corrections direct services. And there's some synergy in there. We all have trouble hiring the same folks. Should be coordinating our contracts for nurses and other staff, and then working in a more coordinated way. So I'm excited. It's not as glossy, but I'm excited about the direct service side. We also need, as a state, to focus on seniors and the aging population. Unlike child welfare, which has systems at the county level or local level, or public health that has health districts, we don't have an entire system for the aging population. This human service reframe will allow us to do that. So I know it's a budget hearing, and that really, we stand for questions on reorg or happy to provide supplemental information as needed.
Thank you, Director Whitley, and thank you, Ms. Weeks, for this very helpful and important information. And before we move on, because the budget and the administration budget and the reorganization are tied together, can you please just do the details for slide 8 and 9 before we move on to questions? Thank you.
For the record, Richard Whitley. So on slide 9, these are decision units for budget account 3150. Is that what you're wanting me to go over now? Okay. Again, for the record, Richard Whitley. Decision unit E257 is a general fund request to continue funding contractors to assist the director's office with facilitation, program evaluation, training, project management. We have found that this has been a great help. I never asked for, but like in years past for a contractors, we usually move our funding from unspent personnel to contract for direct service. But this has been helpful. Actually, my when I introduced in the last meeting my acting deputy, because my previous two moved to the governor's office, which I'm grateful for. But she was a contractor out of state and moved to Nevada, and either through my pushing or the environment is nice, but she accepted the position as the director of deputy director over our finances, and this position helped me to do that. And so I respectfully request that we continue to have some funding in contractual. Moving on with decision unit E258, this position is funded with opioid funding. Position E500 is cost allocation, and I'd be happy to answer any questions.
Thank you so much. And we have several questions from our committee members, and you may go directly to the member, and I will start with Assembly Member Brown-May.
Thank you, Chair. Thank you. Good morning. Thank you for the presentations. Great to see you all this morning. I feel like you were just here. Well, you were. Very robust, lots to consider. I'm going to start with this, right? Ms.
And
Lee-
I'm sorry to interrupt you, Assembly Member, just because of the mics. Everyone's going to be very loud today. Thank you.
Wow, I've never been asked to be loud, but that's good. Thank you. I appreciate it. I will do my best to be loud. Thank you so much. I'm wondering if you could talk about, you talked about the costs, right, and how we can increase purchasing power. So can you talk about what are the barriers that we're currently facing that prevent the Department of Health and Human Services and the Silver State Health Insurance Exchange, the Public Employees Benefits Program, from negotiating more favorable contracts with insurers and pharmaceutical companies? What's the barrier right now?
Madam Chair, Stacey Weeks for the record. I think when you have a small population like the state employee plan on its own out there, there's just there's not much leverage for the state, and you see it in the procurements. And so I think that is a challenge by moving it under with us. And if we can align contract requirements in a way to require plans to participate in a way they don't today. Also, we saw it with the public option. Recently, we just did an intent to award, and 3 carriers met their targets, or they wouldn't have gotten the intent to award. So I just want to be clear that that purchasing strategy is a similar one, where we are asking plans that participate in a Medicaid to try to do better in the market. It's not perfect. There are obviously ups and downs to that, but our state employees, we think we could leverage Medicaid in a way that we are not doing today as more of like a large employer. I mean, the state covers all of these lives, and by putting them together, we have more of an opportunity to have more leverage.
Thank you. Follow-up, Chair? Yes. Thank you. In the presentation last night, we were really looking at Medicaid savings, right, and impacts to the costs associated that could potentially save money for the state budget. Do you have specific cost savings that have been identified by the agency that could result from this combined purchasing power of healthcare?
My mic is doing funky things here. Okay. See. Stacey Weeks for the record. Oh, we do want to switch? We'll dance, yeah. Stacey Weeks for the record. So to do that type of savings, I would really want to get a modeling. And so one of the things in the budget BDR and some of the funding we're requesting in one of the enhancement units is to get a vendor on board to do modeling. Say it would be irresponsible of us to try to predict at this point if we don't have the expertise to model the different scenarios. There are different ways to do purchasing. And I think what we want to do is, with this part of the budget BDR, outlined a strategic plan that we would bring back to the legislature in the interim, outlining different models, and obviously with the PEB board too, and walking them through options where we think we might be able to leverage and get a better deal, how much savings that could be. But that would not be for this biennium. Any savings in this work would be for the next biennium. I mean, I will just be honest, purchasing and the way our contracts are currently done is very siloed and very not aligned, and so we would have to also work on making sure we're aligning some of that work, which will take time. So to answer your question, I think we will have more answers if this passes and we get the vendor support we need to do the modeling.
Thank you. One more, Chair, if I may? Yes. Thank you. Thank you. I have so many questions, so most of them I'm happy to take offline. I really look forward to having this conversation ongoing. You brought up modeling. Modeling can be done in lots and lots of ways, but I'm curious to know, overall, with regard to this presentation and the separation, have we done modeling or looked at other examples from other states? Is there a place where this works now?
Stacey Weeks for the record. I mentioned the Nevada public option. That's one example that worked. It's a smaller example. I would say that Oregon, Washington do this model. They've had this model in place for some time. There are different variations on it. New Mexico is also looking at another model similar to this to try to figure out a way to have some leverage with carriers, because it is very challenging when you do not.
Thank you, Assembly Member. Next, we have Senator Titus.
Thank you, Madam Chair. Administrator Weeks and Director Whitley, thank you very much for being here today. Obviously, it's a very challenging situation. As I tell people, healthcare, if it was just about taking care of patients, it'd be one thing, but there's so much convoluted government oversight and payer source, and it gets very difficult to understand and break down. So thank you for trying to give us a presentation that breaks some of that down. My question really is on the fourth slide where your third slide, where you talked about Nevada being the growth rate in healthcare cost is the highest of any country. Is that in Nevada or highest in country? So that's over all states. And if so, what do you attribute to that? And where might we look for some of those numbers and how we rank that way? And I know that you're trying to fix that with purchasing powers and stuff, but there's more to it than that.
Madam Chair, Stacey Weeks for the record. Yes, there is definitely more than that. This comes from Kaiser Family Foundation information. It was 8.9% annual growth. And I apologize, I should have had the citations on this slide for you, and I can follow up. I think there are a lot of factors. Nevada is primarily a for-profit state. When you look at hospitals and plans, there are other states that have a mix of nonprofits. I'm not saying for-profit is all bad, but I do think there is a dynamic there that is in play. I also think that we haven't had the leverage that we need sometimes with carriers. But I think the reason you'd want to do this for the state is so we have some ability to try our best to control that impact to our budget.
Thank you for that, and I look forward to seeing the referral in the Kaiser. And thank you, Madam Chair, for the question.
Thank you. Assemblymember Hafen.
Thank you, Madam Chair. And thank you guys for being here today. It's good to see you. And in concept, I'm enjoying what you guys are proposing. I look forward to seeing how it all works out. I think there will be some cost savings and some benefits to the community with streamlining the process. One of the questions that I had is that the breakdown of some of the different agencies and at the commissions and boards. I know there's a bill floating around to consolidate, shrink, get rid of, eliminate, whatever you want to call it. Are any of these being proposed to be cuts that fall under your categories? I haven't read the 3,000-page bill yet, so thought I'd just ask the question.
Madam Chair, Stacey Weeks for the record. Well, that's not our bill, but there are different elements, like a couple things are under that bill, but my understanding, those things are being amended out so they would not be impacted.
Perfect, that's good to know, because what I didn't want is one to be one board here and one board there, and then they get merged together, and now we got to come back and figure out how we're going to split it up. So glad to know that you guys are working on that so we don't have those headaches. Thank you, and thank you, Madam Chair.
Thank you. Senator Nguyen.
Thank you, Administrator Weeks and Director Whitley. I have lots of questions, so please bear with me, and please bear with me, Chair, for your indulgence. You kind of highlighted some of the specific issues that you have under the current way that we are structured around Medicaid, the Silver State Health Insurance Exchange, as well as PEB. And you believe that this will be resolved through this reorganization and the creation of this new upper management team, inclusive of this new director and deputy director and administrator position. Can you give maybe some more details on why you think, what are the high level things that you know you will see immediately?
I'll just take a start at this. For the record, Richard Whitley, on identifying the problem maybe, or even our approach to trying to resolve it through the system as it is now. And I think I mentioned this in the pre-session hearing, but we tried with pharmacy. We looked at how many, like the purchasing of pharmaceuticals. And I think I said in my presentation that there were over 50, but there's nearly 100 separate purchases for pharmacy. The pharmacists tried to, not meet with all of the agencies, but with the larger ones. And there were varying levels of understanding of what rebates were, of public health service pricing. Some contracted with a contractor who contracted with someone else, and so it was very scattered. And we tried to actually, because we thought maybe we have this wrong. Purchasing, would it be better to have a subject matter expert with you, a pharmacist with you, in order for us to do this? And they weren't interested and it didn't make sense, and we would have gotten that one thing, and so that was an example of just our sort of pathway here. Is we did try some of the existing systems, even cynically, if we thought they won't work, we did try to see if there was an interest, if there was synergy there, and that pharmacy piece really started moving us in the discussion. And Stacy can give more details in different areas, but that pharmacy was the big one. I think we summarize it as purchasing power, but there's more to it. It's really understanding all the purchasing strategies, and not having staff that do functionally different roles when it comes to purchasing pharmaceuticals.
No, thank you. That actually kind of leads me, set up my next question. Around that, needing kind of, I guess, specialized administrative positions that are skilled in some of these like extremely complex areas, I think is important, and I'm very supportive of that idea and that policy. But do you have any, considering that most of these positions, these administrative positions, I think like 75% of the time has to be spent on Medicaid programming? How does the agency or this new reformulated agency intend on implementing statewide programs and health care purchasing strategies with non-Medicaid agencies?
Madam Chair, Stacey Weeks for the record. That is in the org chart slide. That is how we designed it very carefully, because we do believe HCQC, there will not be most of the time, even though getting people in facilities licensed does help Medicaid. But we are not at that point doing that because we need to talk to CMS more about those efforts. But all those other efforts are all Medicaid under that bucket. Healthcare financing and budget. The majority of this budget majority of the state budget will be Medicaid. That's 75% of that team's time. Nevada Medicaid will be 75% of that time. Consumer health and access, even the PPC today, most of what they talk about is Medicaid. Most of what people complain about is Medicaid. Most of my life is Medicaid. State exchange, we're moving the eligibility and enrollment system into that exchange, so there is a better option and streamline it in real time. That will be a big piece of this work, and we will be careful and also, if employees are not doing 75% of the time, we won't fully match that staff. You will only do the match for the portion of their time, and we have a time tracker today that we do this. We have the dental officer with us today who does a lot of Medicaid, but we keep up with his time because sometimes if he's not keeping 75%, we are careful how we match that. So we have a system in place, and that's one of the reasons we wanted to bring that budget team and that accounting and that time tracking team to the director's office, so we make sure that if we are matching federal dollars, it is appropriate across all of these. The exchange maintains a separate budget for that very reason. Public employee benefits maintains a separate budget for that very reason. Public option maintains a separate budget for that very reason. GME fund is separate, but there are opportunities that we have not yet leveraged that we will work with CMS, but we will have the appropriate authorities, I promise you, if we are using federal dollars for those efforts. Hopefully that answers your question.
It does. And it kind of answers some of my questions about the separation of those budgets with the public option, with GME, potentially with some, ability to match some of those funds as well. Do you anticipate that you will need any statutory changes to implement the Nevada Health Authority, especially when it comes to that PEB and that Silver State Health Exchange like budgets? And if so, have there been any bill draft requests submitted for those reorganizations?
Madam Chair, Stacey Weeks for the record. Yes, there is a budget BDR coming. It's very large. I apologize. Because there are a lot of statutes, but we tried our best to not create a lot of disruption. And so the things that were changed were very minimal. I mean, honestly, the way the Department of Health and Human Services works today, these entities are under DHHS today are very separate. It's a similar thing here. So PEB would come under, be its own entity in many ways, but be leveraging the resources that we can provide and the sophistication on the healthcare purchasing side, as well as the pieces that PEB does not have, like the pharmacy pieces that they can leverage from us, but still be a separate entity, just like DHCFP is a separate entity from DWIS and all the others. So that's what we're trying to create here for them. I hope I answered your question.
No,
So,
no,
yeah,
and I
sorry.
look forward to
Yeah.
what I imagine will be a very, very, very long bill. Chair, may I ask a follow-up with regards to the PEB board? I mean, currently, the PEB board has the authority to direct the executive director on how to carry out the Public Employees Benefit Program. Would you anticipate that they would still have that authority, or would there be some reorganization of that board and the authority that lies within that board?
Madam Chair, Stacy Weeks for the record. Yes, they will still, when we were, so there are two changes I think that are significant that, to talk about. So for the PEB board, it would be the way it is today. The only difference would be they would not be making the final hire of the executive director. They can make recommendations, and that the director of the Nevada Health Authority would be the ultimate hiring person and entity, so that person's accountable to the state government as well, with the approval of the governor. The other piece that's important to note is in that BDR, I think the other significant thing is the board primarily stays the same. So if we come up with a purchasing strategy, for example, changes in how we purchase healthcare for state employees, we would have to take it to that board and get it approved. It's the same as it is today. Now, if in the interim, if our modeling comes back and it's a scenario that requires statute, we will have to bring that back to you in 2027 to make statutory changes to how that program works. But until we try all the different modeling, we don't want to bring something forward until we know exactly what we want to do and that the board has approved that. So that is part of the process going forward. I would just note that there are term limits too in the board. Currently, people are on there for a very long time. There are new term limits in that board, but primarily everything else stays the same. On the exchange, there are differences in the board. The board becomes a more advisory role, like other states. It's an advisory. It can be advising over governance and operations, but primarily as the website and the functions of that entity would be more ran by the Nevada Health Authority and that executive director.
And then finally, the thing that I think sometimes we get so technical in here, what will we be able to go back and tell our constituents? Like, how does this impact, the over 800,000 people that are currently receiving our participants in Medicaid? Like, what are they going to see? And how is this, like, potentially more oversight and more increased oversight, I should say? Is that going to make it, are we creating more red tape? Or what are they going to see?
Madam Chair, Stacy Weeks for the record. I think the goal is to remove red tape and make these processes easier. I would say for Medicaid, I hope that what Medicaid gets out of this is a larger system that is working together, so our efforts are not in an echo chamber, right? That we have a larger effort across the state that is helping and support the same thing. We all want better access, and that's one of the first things we need to make health insurance work in this state. And so I think this new entity is really supporting Medicaid in that way that we don't have today. With the GME pieces, it's in our budget as well to put money into more workforce efforts to match. That is really Medicaid's biggest challenge, other than cost, is really, can we find providers? And same with PEB. I think they have probably a bigger challenge than Medicaid. We hear all the time that our public employees cannot get a provider or don't have a full, a sufficient network, or they don't feel like they do, whereas Medicaid often does. And so I think that is the goal, is to figure out how can we do that on both sides, but also improve access and timely access to services.
Thank you so much. I know we have a lot of questions because it's so important, and we really thank you. Next, we have Senator Dondero Loop.
Thank you very much. So I appreciate you being here today, and I appreciate the information. With the integration of PEB and the health insurance exchange, can you give us an estimated timeline for that implementation?
Madam Chair, Stacy Weeks for the record. So I think right now the way it's in the bill, July 1, that would be the transition period. So it would be effective then, but we would be putting together with DHS and other entities a transition implementation plan. No major changes would happen. They would continue the way they do today. They would just we'd be working on what is that structure now that they're part of this new umbrella. In October, though, we are, so in July, we start also hiring the deputy directors and other positions at the agency to try to build up that infrastructure. And then in October, we can hire the rest of the staff that we've asked for. But PEB and the exchange immediately as of July 1 would be reporting to the Nevada the Health Authority, and working together to create an implementation plan and a strategy to work together.
Thank you for that. So as a customer, will they be able to access as of July 1, or will it be October?
Madam Chair, Stacey Weeks for the record. There will be no changes to the front door for consumers.
All right, and then just as a follow-up to that, what I know you said there will be no changes, but I would assume that there is going to be some impact on ongoing services and operations when you implement some of this. Am I wrong?
Madam Chair, Stacey Weeks for the record. No, because we are not moving PEB as it is today. It's just coming under an umbrella. And then the larger strategy here is to work with the board on how to get a better deal for state employees, and that's going to take time. We're going to do some actuarial modeling, bring in some of the best experts nationally to help do that strategy, bring it back to this legislature, which is in the BDR, as well as the board, so that and before we move forward on anything, there would be plenty of time, but it would be part of a contracting procurement strategy.
So initially, if someone was a customer, they wouldn't even know this was going on unless they were following it.
Madam Chair, Stacey Weeks for the record, yes.
Okay, thank you very much, and thank you again for your time. Thank you, Madam Chair.
Thank you. Next, we have Senator Stone.
Good morning, and thank you very much for the presentation. Mr. Whitley, you talked about the importance of preventative care, and that might have been a shortfall of the Obamacare. With this reorganization and the impact of preventative care and lowering costs, and talking about that we have the highest costs in the nation, basically, or in growth. Do you see the incorporation of preventative care in these programs to help try to lower the cost of delivering health care here in Nevada?
For the record, Richard Whitley. Yes, I think there are. We actually, we didn't just have an idea. We've been working with the entities. We did look on the public health side and identify, and just for my characterization, I think the Affordable Care Act never implemented completely on the preventive health side. And so, but in theory, it's there. Preventive health is covered. We don't maximize like you'll hear later today on the budget account fund for Healthy Nevada, which is tobacco settlement. There's a large part of that funding that funds tobacco cessation. It's a required preventive health service that we don't currently leverage with Medicaid. We looked at that. We have family planning that is funded in public health that could be leveraged with Medicaid. And so there are some specific examples like that, but working in the rather than waiting for a disease with public health and then responding,
right,
but integrating. We're already doing the tools. So we thought we could put it all together with public health, the regulatory side, and the unwinding in government is I think the biggest, as you can see, Stacey Weeks is a brilliant person in healthcare purchasing, and it's the bureaucracy that wears you down.
Right.
We'll wait till she retires, somebody else to be able to effectuate change. And so we tried to, we started this with the thought of incremental, really, let's neither bite off more than we can chew, but let's also not chew more of a little piece that we bite off. Let's do some sizable chunks here. But I do believe that there's benefit in that. We will continue to work together and leverage that. But things might happen during this session at a federal level where it's like, we've got to leverage dollars in every place. So we're still interested in it. We just could not get it. I couldn't undo the administrative support that DPBH gets from having public health. Honestly, that is just to cut through to what it was. It would require more general fund. You'll see that in some of these movements, some offsets. Begs the question. Well, if you're reducing work, you should reduce the staffing or send the staffing. And it isn't that it isn't that direct one for one, and so some agencies do direct cost allocation and spread the administrative funds. Some do the matching and the time tracking and everything, grant funding. It is so complicated, and I really, to the degree that I can, try to remove that from Stacy so that we maximize the skill set we have. And pretty remarkable in terms of bringing a team together and effectuating change in Medicaid at the top.
Thank you. I think leveraging those funds for preventative care can greatly have an impact on lowering our costs. And Ms. Weeks, I think it's brilliant that you're looking to hire a pharmacist or a pharmacist team to leverage the many generic drugs that are within the same pharmacological class and trying to get the best deal, and the brand name drugs that have the same pharmacological mechanism of action, and trying to leverage them against each other to get better discounts, if you will. Have you thought about the wisdom of having a specific PBM for just Medicaid patients? That is another additional tool that could probably save millions, if not hundreds of millions of dollars.
Madam Chair, Stacy Weeks for the record. Thank you for that question. Actually, we have the first step. It's in our budget, actually. There are two things. So there's a single prescription drug list that we haven't done across our Medicaid program, which we're going to be asking money to implement, which is including another pharmacist. We have one on staff. We're bringing in hopefully another one. And then in our vendor funding, and part of the budget BDR is to explore pharmacy strategies, one of which would be modeling a single PBM. But we want to be thoughtful. Those things don't, it's a big lift for a state. Ohio did something similar. It's not easy. So we want to be very thoughtful in doing that. And so that's one of the reasons we wanted to get the funding so we can start modeling things and be like, what does this mean for the state? Is it really going to get us, is it more work than it is worth, or is it worth it, right? And so that is something we're looking at.
Great. Thank you very much.
Thank you. Senator Cannizzaro.
Thank you, Madam Chair, and thank you, Administrator Weeks and Director Whitley, for being here today to talk to us about this. I actually am, to me, a lot of this is exciting. I'm glad to hear so much support for folks now liking that the government is thinking about how it is that we can leverage our purchasing power. This is a conversation that I've certainly been having in this subcommittee and various other committees since the 2019 session, when we started talking about, how we may implement the public option. And I'm excited to hear, obviously, that there has been some wild successes. Part of that, I think, was based upon us being able to do a lot of that actuarial analysis and do some modeling in order to come up with the right balance. And I'm excited to sort of see how that starts to play out in the future. So I appreciate that, and I'm like I said, I think it's great that there are so many people who are now sort of embracing that as a mechanism for us to help bring down costs for consumers and for Nevadans. I think a couple of things. I have some questions about one of the pieces here for a contractual position. So I want to kind of get to that first, and then I have some additional questions about some of the things that we've been discussing this morning, if that's okay, Madam Chair. Great, thank you. So last session there was some appropriation that was approved for one-time contractual support within the director's office. We were told that need was temporary, that the general fund appropriation was for that contractual piece to do some management analyst pieces. That is now being re-upped, even though last session it had been approved as a one-time fund for that contractual position. So can you talk to us about the funding for recommended contractual expenditures, whether that is intended to again be one time to address now a different need, which I think you had indicated it would be based more on workforce and trying to help expand the workforce piece of it. And so is that a temporary need? Do you anticipate that ongoing funding being permanent? And I think it's a $320,000 over the biennium, $160,000 in each year.
For the record, Richard Whitley. I probably said in the last session, one-time funding for the purpose that we were. I would say we're a lean agency, and when we have budget shortfalls, I cut from the top. I mean, to a detriment sometimes of not trying to have impact on direct services, but what we did see was a benefit, and as needs occur, like we resolve, like it did the purpose of having it, but other needs emerge that really are not like a dedicated state FTE. I load people up with work, but there is a point at which that we need the flexibility to have some contract. I would identify that as just in this overall presentation is one of the benefits, I think, and one of the things the legislature did last session was with Medicaid giving some contractual. There was a time when the staff at Medicaid would write the RFP for managed care, doing the best they could, but it's like this, like we don't have that skill set, and so I just have had emerging needs. I do want to focus on the direct service side. We don't in the Division of Child and Family Services. You've heard in IFCs and discussion about the campus at Southern Nevada, the facilities that are needed. What role does the state play? What is a safety net provider for children's health? Those should be determinants that we're looking at and that everybody knows it, not like I have a child, I need to place them in an unlocked facility with this wraparound service. Where do I go? They languish in child haven if we don't have the facilities. And so I respectfully just say that this is a small amount of money that could very much help me. I'll figure out how to do it if it is not approved, but.
Yeah, no, and I appreciate that. Director Whitley, I think we were trying to get a sense, since last session when we heard it, it was one-time funding, and now it's coming forward again, and so trying to get a sense of whether that is something that should be ongoing or really is kind of one-time funding. And I know you're doing a lot with not probably all the people that you would love to be able to have and all the resources in order to do all of the things that you're doing in your department and certainly within Medicaid. So I appreciate that and appreciate all the really hardworking people over there who are making it work. So a couple of things. I know we were just having a discussion about preventative care, and it sounded to me like the answer was that we really are focused, and I think going back to this reorganization, really are focused on figuring out how we better leverage the ability to get that care, not that that preventative care is not available, because as I understand it, the ACA actually provided a lot of free preventative care, especially cancer screenings, mammograms, and prenatal care, and all of these different pieces that we know help improve outcomes. So if I'm understanding your answer to my colleague's question previously, it's not that the ACA did not provide preventative care or somehow diminished that. In fact, it actually expanded preventable care and made that free for and covered for many, many more people. But some of the difficulties that you all have been having is being able to leverage that. And some of the solution with this as a mechanism is to be able to do that a little bit better, to leverage all of the pieces to help expand access to those preventative care services and get more people to actually go and do that preventative care.
For the record, Richard Whitley, I apologize if I misspoke. I didn't get the nuance of the question, but I think that at a federal level, the agencies like CDC, like I'll give a specific example. CDC funds a breast and cervical cancer screening that if you're eligible, then you can qualify for Medicaid. If you need a follow-up treatment. But Medicaid also, under the preventive health, covers breast cancer, mammography and screening, and the treatment. And so in our state, that is the Women's Health Connection in public health. But what we haven't got to is the outreach side. So I think I'm talking more about, even with family planning, easy. For right now, it's probably easier for people to get funding, direct funding, order products of birth control and not have to bill Medicaid. We want them to bill Medicaid, and we want to use flexible funding where it's not covered. Family planning is the same way. Outreach to, and I don't say family planning is just a euphemism for birth control, but truly, if a woman of childbearing age is substance using, outreach to find them and do harm reduction with getting them into family planning, which may be an entry point into primary care. What I'm speaking to is leveraging the dollars so that for outreach we could cover what isn't covered. So if I misspoke, I apologize for that.
I don't think you misspoke directly, Whitley. I think we're saying the same thing. I think that it's interesting to hear that it really is a mechanism of being able to do that outreach more effectively, and how it is you leverage those dollars to work a little harder. So I think we're saying the same thing, and I appreciate that. So I did send over, and I know there was mention of it previously, I believe last night, myself and our finance chair sent over a letter because I think that there are some questions and some concerns that we would like to have, I think, a better understanding of as we move forward in the budgeting process. And so I know you acknowledged we've received the letter, which was a request for some information regarding Medicaid and potential impacts. And I think when you were answering some questions today, you made brief mention that uncertainty at the federal level may impact that as well. So that letter had a deadline in it, I believe, of February 18th. And so I wanted to know if that feels like a workable deadline, or if we would anticipate that that is too short a time frame to get some of these answers.
I mean, for the record, Richard Whitley, I mean, I think at any time frame we would share what we know. I think, you know, on the day some of the announcements came out, I was having a meeting with a nonprofit network of nonprofits, and you know, it would have been tone deaf not to acknowledge, but everybody had the same information I had, and it was like hadn't landed yet. And so I think that you could pick a point in time. It probably is required updates as we go along, and I think we've done this before with other challenges at a federal level where, like, we don't know yet, but we have to proceed. It does make it hard because sometimes you want to anticipate the worst, and then it's like, how do I take care of that? I assure you we do. Every time there's a threat of a budget shutdown, I do the same mechanism that Mike Wilden did when he was in my role, which is we identify the federal funding. How much do they have on reserve? How much, you know, like particularly with food, like how long can people access it? And, you know, for a few years it didn't land anywhere, you know, but we did have shutdowns before. And the hardest part is when the feds don't communicate. And they had some furloughs and in the past when there was an economic downturn and they couldn't reach an impasse at a federal level. That was probably the hardest time. But we go through the same drill of like, what if, you know, if we have to reduce. And so I've kept that up. Just as an exercise, never turned it into anybody, but it's like just if. And so there's a lot of unknown here. And, you know, for me, I'm hearing I heard on NPR a story about Northern Nevada Hopes, a federally qualified health center, and people just out of fear were not coming in for primary care. A lot of mixed immigration status families, and you know, just the unknown part. I don't want to participate in the unknown of amping up fear. So you know, I've tried to manage it that way. We've tried to share with our own staff who are conduits out to the community. But that's a long-winded way of me saying that we'll provide you by your February 18th due date what we do know, but it may not. But there may be areas we still don't know about.
I appreciate that. And obviously I'll look forward to taking a look at that and then getting any updates as time goes on. You know, the purpose of the letter was to recognize that there is a very real discussion, and so not stoking fears, but a very real discussion at the federal level that Congress may make significant cuts to Medicaid in order to fund and to finance, you know, $5.5 trillion in tax cuts to large corporations. If that happens, I think that this body and this state has to be prepared for what that looks like when we have 800,000 plus Nevadans who rely on Medicaid, and cutting those services would be extremely detrimental to them. That would also put this particular body, should that happen outside of a legislative session, into a place where we would have to come back into this building to cut significantly budgets that we have, because that federal funding is incredibly important to how it is that we are providing those services, to how it is that we are funding all of these pieces that we are discussing in this subcommittee and in our larger money committees, and the whole of this legislative session. And so I look forward to getting that information just so that we can be sort of clear-minded moving forward, because that is a very real discussion. And I think being able to understand the impact that that would have to everyday Nevadans is something that we should absolutely be prepared for. And so that's more of a comment than a question, but I appreciate your willingness to work with me on that and to get me that information so that I can share that with my colleagues, just so that we are very aware of what that sort of cut to funding and to services here in Nevada would mean. So thank you, Director Whitley. Thank you, Madam Chair, for the time.
Thank you so much. And our last question on this item, Assemblymember Hadigi.
Thank you so much, Madam Chair, and thank you for being here. Thank you for being here for the presentation. I have questions regarding the Office of Minority Health and Equity. I know you're looking for a new position, the Health Program Specialist position, and I appreciate the work that the office has done in identifying and acknowledging that a lot of the communities have health disparities. And so my question is regarding that. I knew that this new specialist programmer that you're requesting is specifically to help the communities who are facing health disparities. So can you give us some details about those communities? Who are those communities, and what specifically how this position will be helping them? Thank you.
Sure. For the record, Richard Whitley. So we do have established in statute the Office of Minority Health. It too is on a shoestring in terms of it doesn't do services. It mostly is a conduit to access with a coalition that is statewide. But one thing that we found, even in having funding, like with opioid settlement funds, is that we followed a process of, an announcement. We had several faith-based organizations that are nonprofits send in letters of intent, but they never sent in applications. There's some pre-work. We have one in Northern Nevada, a faith-based organization, Accept. They have a nonprofit ran by Reverend Taylor and his wife Connie Taylor. They've been functioning as a nonprofit in a faith-based space for 20 years. They started with HIV. They promote breast cancer screening among their members and among people who maybe get their information in that setting. And it was striking to me that when we had, because it's like, here's a resource. We want to help do primary prevention with the youth. You have them in church, and there was interest, but they weren't the organizations. And I've gone through this too many times to set up an organization where we fund them, and then they can't manage the funding. So my intent here is, and Tina Deutsch is doing a terrific job, and this is the best placement for that position, but outreach to faith-based organizations focusing on African American and Hispanic populations specifically, who sometimes use the church as a place for getting information. And there are evidence-based programs on cancer screenings that take place in a church setting, and so that's the intent behind it.
I know it's a pretty lean office, and so you guys work with contracted positions as well. Will adding this position help minimize how many contracted positions you guys have to have?
Well, because I misspoke last session, for the record, Richard Whitley, and said I wouldn't need contractors again. I don't want to say that. I think that we do rely a lot on grant funding. I, again, have to see what happens at a federal level in terms of funding, how to also, when health status is bad or health status is good or improves, it doesn't always improve for everybody. And so, a big part of that is to be informed and use our data analytics unit to identify with information. That's the wonderful job that Tina does with engaging communities. So adding this other piece, position will help with that. But I can't say that, we also wouldn't turn away a grant opportunity.
Well, thank you, and thank you I appreciate what this office does, and thank you for identifying these communities and working to bring resources to them. Thank you.
Thank you. Thank you, Administrator Weeks. Thank you, Director Whitley, and thank you, subcommittee members. Seeing no more questions, we will close both the overview of the Nevada Health Authority and the budget account for the Director's Office of Administration. We will now open the hearing on the Fund for Resilient Nevada, which for the public is also our opioid settlement account. And Director Whitley, you may begin.
For the record, Richard Whitley. So budget account 3060 is the Fund for Resilient Nevada, the opioid settlement funds. 43% of the opioid litigation recoveries are managed through the Fund for Resilient Nevada. Local governments are part of the One Nevada agreement with the Attorney General's office, and they receive funding directly. We have presented in the past, DHHS is working to make generational impacts, really. If you sit on IFC, we've come to multiple IFCs with requests to focus on prenatal to young adult and children. And we continue to do that in this budget. I think that the flexibility of this funding, as outlined in statute, has allowed the department to address emerging needs that occur in the community. And I think it's doing what it intended to do. We can't just willy-nilly spend the funding. We have to come to IFC. We do that. The statute, I'm going to follow my slide. Then moving to slide 11. This outlines the decision units using opioid settlement funds. They're broken out by population here. You could go on our website and see how it's broken out by funding and by goals, but all the goals aren't relevant to all the populations. Maybe getting back to the minority health question earlier is by age or by even geographical area, all things aren't the same. And so we've comply with the goals that are in the statute and required for us to follow, but we do a population overlay. And you can see in the slide that we presented, we sort of organize them in a different way than by goal, which is really kind of hard to track when you're looking at making some improvements. Because these funds can prevent, they can intervene, and they can treat. And that's essential with youth. If you think about it, young people their mother may have used substances while she was pregnant, and they be harmed by that. They may be living with a parent who's using substance abuse, and child welfare intervenes, and they are harmed by that. And then the child themselves, as they grow into an adolescent, is at risk for using drugs. And so there's prevention needs. And so I'm trying to stay on my PowerPoint and not go off. So you can see the organization or how we organize this to really convey what we're trying to do in the decision units for this budget account. So I'd stop there and answer questions if that's okay.
Thank you, Director. And yes, we do have questions. We will start with Assemblymember Brown May.
Thank you, Chair. Thank you, Director Whitley. So I've spent a bit of time in this interim really working on opioids, our current response, harm reduction methodologies, how are we combating overdose, right? And this focus, right, on addressing the opioid crisis that we're currently experiencing is essential. As I look at some of the budget dollars, it appears as though the governor's proposing to decrease some of the funding available, the reversion, and potentially move it into other programs. But it's my understanding there's a plan that's done every 4 years, right? The statewide plan is done every 4 years. And with the timing of the plan and the needs assessment, will that impact the approved opioid projects that we have right now for the 25-27 biennium?
For the record, Richard Whitley, I mean, just as a point of clarification, these funds don't revert. So they go into reserve. And I think I mentioned in our pre-session hearing that we were slow to start, and so we had a lot in reserve. We also, as I mentioned in statute, the local government can't apply for funding unless they have their own plan, and really, and in a nice way. I mean, I think it's a thoughtful thoughtful negotiation, I suppose, on the AG's part to maximize these dollars, something we've talked about today, and so that is how the funding organizationally works, and we're compliant with the statute. As I said, we had a large amount of reserves in the past, but the funding doesn't revert. And we will not be taking funding from other projects. I think as you know, we come to IFC, we present projects. It seemed like the state agency, working with state agencies, that taking a different approach. One project that we have is with veterans. We've never had a application from a veterans organization. It made sense in working with the new director at the Department of Veteran Services, who embraced this as we're closer to the people. We will put that out. We will hold them to the same accountability that we do with every other provider we fund. I mean, we don't want to put these dollars at risk. We have to adhere to the state law, which is an umbrella requirement, and then each pharmaceutical company and each pharmacy has their own negotiation. And Dawn, who's quiet, but she is the manager of this program, she makes sure that we are in compliance. We do not, as ARPA goes away and other flexible funding goes away to address problems, this becomes one that really we have to rely on to, and if we can intervene in these generational, this generational harm that has been done, I think there's great benefit. It's still growing though, the capacity. I mean, there is a organization in Las Vegas, Empowered. They're a program within what's the hospital? Roseman Hospital, and they started off slowly, but now they're statewide in the rurals, and they're the case management conduit to OBGYN. That wouldn't have started without these dollars, and there are next steps in terms of growing that. But the flexibility of the funding, I have to think, was intentional to be able to allow us to fill gaps. The actual medical services are covered by Medicaid. We don't want to duplicate. There are several categorical federal grants that address opioid. And so Dawn has to keep a matrix going of what's covered. And if, to not supplant, we can't supplant this, the opioid settlement uses the same concept and definition of supplanting that the feds use with a grant. You can't free up general fund or local fund to do something else because these dollars came along. We hold it to the same rigor as that, but there's no intent to reduce anybody. We are just using the opportunity of the budget period to put it in the budget. We had richer conversations with the agencies, which was one of the benefits. It kind of went with our restructuring too. So if I may, there were a couple of questions that the AG's office had that we're addressing. One was in one of the items under early intervention. just by title, it reads like it is supplanting because it is funding a policy. But one of the things we identified is with this increase in gestational exposure to substances is those babies get referred from the hospitals, the birthing hospitals, to early intervention. And so we'll clean that up with the language because it is to get more, to have policies and protocols in the system of early intervention, but it's not replacing general fund. And then the other one was with the assessment center. That I'm providing more clarification. And it's been a wonderful working relationship with our AG, Deputy AG, and with Mark Kroger, who's been the lead on this, to actually, if we have a question of if it doesn't comply or not. And so we have these two items that are in this budget that I'm providing additional information on, that the new service, so not supplanting, assessment center for youth who are in the juvenile justice system. Right now, as of now, there were 8 kids sort of languishing in juvenile justice who need mental health services, and the ticket for that is a proper assessment. And so we do believe this would be a good service, but I need to provide, we did a budget amendment. It was percent funded based on the burden as our data analytics folks showed us. And then doing a budget amendment to make it 100%, I'm needing to show my work on that and will. Because as the statute allows us to focus on primary prevention also and intervention, as well as those direct services. And, I'm going to provide that, and hopefully it'll be in compliance and we can move forward. But we aren't supplanting, we aren't reducing. We have some new projects using the budget authority because they're with state agencies. We will monitor them the same way.
Thank you, Director Wickley, and I appreciate the reserve reduction clarification as well. Thank you for that answer. Thank you, Chair.
Thank you. Next, we have Assembly Member Yeager with several questions.
Thank you so much, Madam Chair. Give me 1 second. Director Whitley, I wanted to ask about building off the question you were just asked about the future needs assessment. I pulled up, NRS 433-736 talks about, what that process is. And I think we've had this discussion before, but I look at the 7 key goals that we have now, and what I think is missing there is family members of folks who have died from opiate overdoses. I do see in the statute, one of the things that you're tasked to do is to get input from persons and families impacted by the use of opioids. And so I know you're going to go through that process, but is there a possibility to look at expanding the goals to potentially include family members of those who have passed? Because I think that is the group that really seems to be left behind when I look at the 7 goals.
For the record, Richard Whitley, yes, I should have probably acted because I remember the same question last time. I think we're trying to work through the stakeholder groups and various entities that serve families and children, and certainly that could be a covered service. And so we need to get there, and we need to figure out a way how to put some parameters around it, but support families who, we do this with kids who've lost a parent. We use some fees from some reserve fees from Vital Records, and we support an organization in Las Vegas and in Reno for kids who've lost a parent, and it's a wonderful program, a nonprofit. And so I think in this space there is more work to be done, but certainly that impact on the child and the relatives who are trying to support a funeral and launch the child in a healthy way. It goes along with all of that. I don't know how to do it. I mean, I don't know how to frame the program, but we'll follow up. And it's not. No one has applied, but it doesn't mean it's not allowable.
Thank you for that response. And, I've read I've listened to a few audiobooks over the past few months about the opioid epidemic. And, what comes through loud and clear on that is just the broadness of the epidemic. And, you have very young people dying, and the impact that it has on their surviving parents. That kind of came through loud and clear in some of that I was reading. And I know this is a challenge, but my request would just be to try to think about some of those folks, because I think it's not necessarily obvious because they're not dealing with the crisis directly in a way that other folks are. But I don't have another question on that, but just a request. And I'm happy to try to work with you on that. Madam Chair, if I could, just a few other questions. I noticed in the budget, the governor had recommended $65.7 million over the biennium for opioid-related projects, but I think your agency said that was overstated by $14.8 million. So I just wanted to confirm that the base funding for opioid projects should be $25.4 million in fiscal year 2026 and $25.3 million in fiscal year 27. And I can repeat those if you want, for a total of $50.8 over the biennium.
Christina Hadwick for the record. So in 2026, we have expenditures of $56.2 million, in 2027, $58.7 million. Can you repeat your numbers again?
Yeah, what I have in my notes, I had that the governor's recommended budget had a total of $65.7 million over the biennium for ongoing previously approved opioid-related projects. So maybe I'm asking the question the wrong way, and I thought we got from the agency that was $14.8 million more than it actually was going to be.
Yes, I believe that's correct. Christina Hadwick for the record. So the ongoing expenditures, that would be correct.
Great. And so my second question is, I don't know, hopefully you weren't paying attention to the budget hearing last night, but we got a number of budget amendments from the governor's office. I don't believe we received an amendment for this because their budget still has $65.7 million, and I think that's $14.8 million higher than it should be. So my question is, do you intend to submit a budget amendment or work with the GFO to submit a budget amendment? Because that's $14.8 million, and that's a significant amount.
For the record, Richard Whitley, from the agency, we did submit a budget amendment. I'll track to see where it's at. But it was what I was speaking to earlier about the assessment center. And
Okay, thank you, Chair. And I might be wrong about that. I don't remember hearing last night about this particular item, but if I'm wrong about that, I'm wrong about it. But if we could just confirm that we have that budget amendment to make sure that the budget is accurate in terms of the ongoing expenses. A couple more questions, if I could, Madam Chair. Mr. Whitley, I don't know if you received, we received some public comment document from Mobilize Recovery from Ryan Hampton, who runs Mobilize Recovery. Have you had a chance to look at this?
for the record, Richard Whitley, no, I have not.
Okay, we'll make sure you get a copy, and Mr. Hampton has worked quite a bit on the opioid settlement litigation, and so he expressed some concerns in here about some of the projects that the opioid money was being used for, and I have to be honest, I agree with some of the concerns. So certainly can give you this letter, but I just wanted to ask a couple of questions, and they're the big dollar amounts that we're talking about. So when I look at the 27 enhancement requests for the opioid money, the first thing I see is essentially a $5 million a year backfill of temporary assistance to needy families. That's a pretty big chunk. So I know that the justification is that it prevents the misuse of opioids, provides mental health treatment, implements recovery communities, but there doesn't seem to be like a direct link to opioids. And so can you just kind of give me your thought process of how backfilling TANF would be an appropriate use given the restrictions in the law on how we can use this money.
For the record, Richard Whitley, sure. I think there are two big projects that utilize TANF as the framework. One is helping, it's an expansion of the program, but, you know, we probably didn't capture it in the write-up adequately either, but it's, you know, to not have another administrative overhang, we're using the mechanism of TANF to expand for relatives who are raising children whose parents are substance abusing. And so that is a direct, I believe, and again, we consult with our DAG, our Deputy AG, on the appropriate use. The other one, using the TANF mechanism, is, as you know, there's flexible funding within TANF. We have, last session, we put the maximum amount of TANF funding into childcare, because the feds allow for a portion, and we historically never did that. So we're not supplanting funding by the federal definition by investing the dollars into a service. The focus of that settlement fund to child welfare, that's the other specific request. And we do have the data to show the impact. So it's to Clark and Washoe County, focused on the population. And I know it sounds bureaucratic, but if you looked on our website at our data analytics with this population, and I personally had the experience of sitting in Judge Bailey's court and having the benefit of having an attorney, Kim Abbott, sit next to me and explain to me really failures of systems. And this was dual court. It was child welfare and juvenile justice, probably the last sort of opportunity for these kids. And so we want to work with the counties with these dollars to have impact when child welfare has intervened. And so it doesn't meet the requirement for supplanting. The state, the AG uses the federal definition, and it is an appropriate use focusing on this population, but happy to provide more information.
Thank you, Director, and I'd have the same information if you could provide with the Kinship Family Support Program. It wasn't clear to me that there was a link to opioids, and what I don't want to get in a situation is much like I did with the tobacco settlement, where it was received for a specific purpose, and then we just use it to backfill budget accounts so legislators can fund their pet projects. That's not what we should be doing with this money. I trust your division to do that, but I think for transparency purposes, I think it has to be clear to the public that this money is being used as directed. I mean, folks worked really hard to get this money for the state, and so that would be my request with those two. And I do have a specific question, if you're able to answer. The new intake assessment center at the Summit View Youth Center. So I had kind of the same question around that. Like, can you just give me a high level? How does spending money there meet with the goals of the opioid needs assessment and statewide plan?
Good morning, Dawn Yowie for the record. Assemblyman, so when we're looking to fund money, we go through all of the settlements, the court orders, as well as the ACRN, which is the Advisory Committee for Resilient Nevada, all of their recommendations, which they provide to the director's office every even-numbered year. Some of their recommendations include provide specialty care for adolescents in the child welfare and juvenile justice systems, as well as expand treatment options for transitional aged youth, provide specialty care for adolescents in child welfare and juvenile justice systems. This facility itself fits into those proposed goals. And if I may,
Richard Whitley, for the record, as Stacy Weeks testified to, that in one of the relief bills, big bills, there was at a federal level, there was a requirement to provide Medicaid reimbursement for 30 days for kids in juvenile justice. Your bill that on criminal justice involved goes for 90 days, and that's been submitted. And in order to treat, you have to assess, and so this is very important, I believe, and I believe that it is an appropriate setting. We can do better at writing them up. I mean, here's what happens. Budget people do the best they can with writing up a program and probably not reviewed by the program person to get all the detail in it. And for that, I apologize, because I do think a lot of work has gone into this, and work with the county, with legal aid, with all the stakeholders who are trying to protect kids.
Thank you for that. I appreciate that. And I just think with a little more detail, folks who worked really hard to get this settlement money, I believe, would likely be more satisfied about how it's being spent. My final question, which I hopefully is not a difficult one, but looking at the 23-25 biennium expenditures, only $6 million to date. Can you discuss your ability to effectively utilize the opioid funding over the next biennium? Because it looks like it's being rolling out a little slower than we hoped it would. Do you feel confident you're going to be able to spend the money allocated for the next biennium?
For the record, Richard Whitley, I think you heard earlier about the Office of Minority Health and some of that influence. I think one thing that Dawn has been doing is more engagement with nonprofits that serve by population. I think we put out an RFP, and the title of the program, Funds for Resilient Nevada. What does that even mean? Opioid settlement funds, and more descriptive. So we've made more effort in that. But really the slow to start was the community needs assessment too at the local level. The needs are there, and we're trying, it's why we come to nearly every IFC with something that to respond to. That would be my big ask, is please continue to allow, as the statute does, the flexibility, because we can't wait 2 years if people are dying and we need to increase or need first responders. Like, one of the things Don did is, like, with first responders, is they were seeing higher, I don't know, it's not doses, but it was high, they were seeing, like, new drugs that required multiple doses to prevent people from dying, and they wanted access to an increase in milligrams to make available. And it's like, we have to pivot on that quickly, I think, and we have some good partners we work with, but in this, that would be my big ask, that we have flexibility to come to IFC.
Great. Thank you, Director, and thank you for all you and your folks are doing to make this happen. Really appreciate it. Thank you for the time, Chair.
Thank you. And last question on this item, Senator Titus.
Thank you, Madam Chair. First off, I want to note, and I really appreciate the speaker making the comment that we're going to really monitor legislators' pet projects and how this money's being spent. So I think that's really important progress. So thank you, Mr. Speaker. Director Whitley, you've been asked a lot of speculative questions today, and especially about the federal spending. It's my understanding that the opioid funds are coming from the companies. Is it a pass-through that they don't go through the federal government and then they're passed through to you, or do some come directly to you?
For the record, Richard Whitley, they're negotiated by the AG as settlements, and so they're state by state and nuanced that way. So they don't. I think when there's challenges, sometimes the companies have gone to court but the dollars themselves come directly to the
right.
state.
So regardless of what the feds are doing, these monies come to you directly from the settlement funds, right?
Correct.
Is that correct? All right. Thank you. So we have the funds. During my many trips around the state and meeting with a lot of different sheriffs and law enforcement folks, and when we saw this dramatic increase in opioid overdoses. It all happened when our borders really opened up and the cartels were able to bring in these terrible drugs. And so I'm hoping, and since you're being asked speculative questions, I'm going to ask you one. Do you see a decrease perhaps in these overdoses now that we've closed our borders and hopefully will help keep these cartels out of our nation?
Well, for the record, Richard Whitley, I don't know. I mean, I don't know. I think you can see that, on the East Coast and Midwest, there were reductions in deaths, and we didn't see that like in several of the Western states to the same degree. We're digging into that to see, are there things that we could be doing, or are we slower moving? But the source of drugs and where they come from certainly play an impact, and then where we intervene also.
And so follow up on that, if I might, Madam Chair. Just real quickly, if we see a decrease in the overdoses and some of this impact, the money doesn't revert back anywhere. It just stays in your fund. If we can see that perhaps we can get a hold of these tragedies, and hopefully we can spend this money in a different direction. So hopefully we'll see that in maybe one of your next presentations as we can get more data on the overdoses. So thank you, Madam Chair, for the questions. Thank you, Mr. Whitley, and all your team for being here.
Thank you. So we will close this agenda item and go to our next one, which is the Grants Management Unit. Knowing that we all have to get to floor, we are all going to be concise in both our questions and our answers, please. And so we will start, and we're going to go straight to questions. So for our first question, and thank you to our Assemblymember Hedge. Thank you.
Thank you, Madam Chair, and thank you. And my questions are around the Tobacco Settlement Revenue Fund. My first question is, I was looking at the projections, and since 2023, the actual settlement revenue has gone down, but now for 26 and 27, you're projecting it to go up. So can you discuss the factors contributing to the projected increase? The 2025 actual was 20.8, and now we're looking at over 23.7, close to 24 million.
Christina Hadwick for the record. So the projections are based on a 5-year average from 2021 to 2024, I believe. And so that's how historically they've been done, is based on a 5-year average.
Okay, thank you for that. And I just have one more question then. So I know that the last time there had been a needs assessment done was in 2022, fiscal year 2022. Will there be a new Nevada State Health Needs Assessment done anytime soon? And will you let me also, in addition to that, can you discuss the relevancy of the current spending with the last assessment that was done?
For the record, Richard Whitley, definitely on the needs assessment. I mean, one of the communities are needs assessed all over the place sometimes. We a few years ago made a change to utilize existing community level needs assessment, pulling them together, and found it more beneficial to do focus groups or public hearings with the community. And so we will update it. All the nonprofit hospitals do community needs assessment. Using resource to replicate that, it doesn't, to the same people, isn't always beneficial, but pulling those all together in a coordinated way for a community and then checking them out has had more benefit. I can reconcile for you the programming to the priorities from that if it's not adequate. It is, we do post it on our website, but I could pull that out, and if we didn't adequately do it, I apologize.
Okay, and I guess my question was, like, the Department of Health of HHS had done like a formal needs assessment that you published in 2022, and so you guys just no longer do it that way.
For the record, in working with the advisory group, I mean, we did arrive at a different strategy for it. It does get published. If it's not current on there, I'll check on that as well. But it is making, rather than contract for another needs assessment just on this, since some of the risk factors are the same, access to health care for cessation, a covered benefit in preventive health, that we're trying to do it in a more, I think, not economical, but a meaningful way where engage the people who already participated at a community level.
Okay, thank you. And I guess that, I mean, that would be helpful to see, right? Because the last needs assessment I saw was the 2022. So if you guys do have that needs assessment done in a different format, how the spending is helping achieve what the needs were. Okay, thank you.
Thank you. Subcommittee members, any other questions on this agenda item? Thank you. Seeing none, we will go to our next agenda item, which is Individuals with Disabilities Education, Part C. And our question is from Assemblymember Brown May.
Thank you, Chair. Thank you, Director Whitley. Early intervention services is where my question is located currently. Early intervention and individuals with disabilities ed Part C, right? The transition has happened a couple of times. We've moved departments. We've done a lot of changeover. It's my understanding that the governor is again recommending a transfer, right? And separation of powers from service delivery and compliance, as we heard Ms. Weeks talk a little bit about in the beginning. I'm curious to know, how would the separation between compliance and service delivery of the Nevada Early Intervention Services be maintained if that office were transferred to Aging and Disability Services?
For the record, Richard Whitley, you're correct. There has been movement of the program, a program that even long before the pandemic had inadequate staffing and wait lists, moved to a model of working with community partners, which was transformational, largely because of the Deputy Administrator, Ricky Robb, and the state had a role as a service provider and also a conduit to the private sector. We're trying to rely on the private sector because that, for these kids, this is a Department of Education, U.S. Department of Education program. Many families feel as though it is access to health care. It feels like it when you get a clinician. And so what happens is it's birth to 3. At 3, you're no longer eligible here. So there's a lot of transformations that you don't see in this budget, but you'll hear in ADSD where they're really formally working more to leverage Medicaid and reimbursement. And they, at the same time, they built a quality assurance unit internally that wasn't there when these moves were made before. So it was outside of the agency, but ADSD, early intervention, is moving and has to have the role because they fund the nonprofit and for-profit organizations that serve these kids. But they weren't ready at the time, you know, and they were trying to stand it up, oversee it, and it wasn't a system in place. And now it is. Unfortunately for me in government, sometimes the movement of slowness of being able to do what maybe a company that provides services could be nimble to is, you know, it's heartbreaking if an outcome is bad, but it also doesn't have to be. If we could rearrange the program components when elements mature, like in this case, quality improvement. Why duplicate it? We have the same goal to provide standards of care. Medicaid is the safety net because they fund to it. Those didn't exist before, so I think you'll hear more detail on the robustness of this proposal in ADSD's budget.
Thank you, Director Whitley. Thank you, Chair.
Thank you. Subcommittee members, any other questions on this item? Thank you so much. And with that, we will close this item and go to our next item, which is data analytics. And our first question is from Senator Nguyen.
Thank you. You can tell this is not the sexy part of the presentation. Everyone is very excited about the first part. Although I do think of our former colleague, Assemblywoman Peters, whenever I see data and data analytics. So I will be asking those questions with her in mind. To what extent would the recommended permanent positions within the Office of Analytics provide the same program support as those contractual positions recommended for elimination in the behavioral health prevention and treatment budget? No, that's very specific.
For the record, Richard Whitley, I think it adds stability to the program. And, you know, if you recall, this has been incremental policy making. Data analytics was scattered in programs. If you have a big federal grant, you have all the bells and whistles. If it's a state-funded program and we don't have positions, and the analytics may be trying to understand like where to intervene with a child and behavioral health issues, and so it's scattered. And we took the first step of putting it together, relying a lot on contractual staff. You'll see in this as well that we use different classifications in different agencies for what is analytics. And so what we're proposing here is the next step, but it does add stability, I believe.
So I know we made some of those centralized data and analytics functions in the 21 session. So I'm glad to see that that is actually being utilized and being helpful. I guess that kind of leads me into this, and it's probably a similar answer, but can you discuss, a little bit different, can you discuss what other funding sources were considered to replace the transfers from the Communicable Diseases Program to support the new administrative assistant position?
For the record, Richard Whitley, you know, it serves all the categorical programs. This is the hard thing when you stand something up with categorical grants. You should see the management side and the time and effort that people have to monitor for their work hours. And so the goal here, and also in moving this unit with Medicaid, one, non-federal dollars could get matched. That's key. And then to stabilize the funding. We've done a lot in that space and pulling it together so all the tools for analytics can be used by everybody, but the support, you know, of AA is across the board. So there are some positions and functions that just, we don't want to be in non-compliance with a federal grant by having a categorically funded person working across other funding streams.
So it kind of maybe answers my question. Is that why, or could we use a cost allocation to recover any of those costs associated with office-wide support?
For the record, Richard Whitley, if that would be the next phase, if I were still managing it, but Stacy Weeks will take it further, even with the leveraging of funds, and so this is just the next iteration, and it is to get to that stabilized funding. Though it's hard on the employee. It's hard on the management to actually have to do in 15-minute increments your time and effort. What did you do? I don't know. I felt like it was important. We have to do that, and it makes it hard when they're multiple funding streams or a single funding stream, because that employee needs to get paid. And so we have to document it, and it's audited, and we had findings before for not adequately doing it. So it's hard to do all those at one time, but that's where we are headed, is more of a cost allocation and maximizing any federal funds we could.
Thank you. And thank you, Chair.
Thank you. And subcommittee members, any last questions? Thank you. And with that, we will close this item as well as the budget hearings. We really appreciate you, Director, and your staff. We know these are the programs and issues that impact all Nevadans, so we really appreciate all that you do in answering all our questions today. And with that, we're excited. We will close and move on to public comment. Because of time considerations, persons offering public comment will be limited to no more than 2 minutes. I will be taking time, and I apologize in advance if I have to move you on because of the time. When you call in or when you testify, please state and spell your name for the record. To provide public comment by telephone, please dial 888-475-4499. When prompted to provide the meeting ID, please enter 891-4921-4731 and then press pound. When prompted for a participant ID, also press pound. And we will start here in Carson City. If anyone would like to testify and give public comment, please feel free to come to the table. Seeing none in Carson City, we will move down to Las Vegas. We don't see anyone, but oh, there we go. We'll give it a second. Thank you. Please, again, share your name, spell it for the record, and you will have 2 minutes. And please begin when you are ready.
Good morning. My name is Joe Engel, E-N-G-L-E. I am the founder of There Is No Hero in Heroin. In 2011, I lost my oldest son to a heroin overdose. The loss was the catalyst of founding this organization, which has grown into a full-blown service provider for the past 12 years. We've touched thousands of lives. We've been on the front lines of this crisis, co-founding the first all-public recovery high school in the nation, hosting the first naloxone training for laymen in Nevada, and operating an adolescent drop-in center that serves over 300 people annually, all at no cost to the clients. We also provide peer recovery support, outpatient counseling, and operate 5 sober living homes, helping hundreds of individuals rebuild their lives. Despite these efforts, the opioid crisis is far from over. While overdose rates are declining in nearly every state, Nevada and Alaska are the exceptions. This is a problem we can't afford to ignore, and it's why I'm here today to speak about the Fund for a Resilient Nevada. As you know, Nevada has received 9 opioid settlement recoveries, totally significant funds intended to address the opioid crisis. These funds are governed by NRS 433, 712, and through 744, which established the Fund for Resilient Nevada. The National Settlement Agreement requires 85% of these funds be used for opioid remediation efforts, and only 15% allowed for non-remediation expenses, like legal fees and/or administrative costs. However, I have serious concerns about how these dollars are being allocated. Here are my key concerns. Number one, broad and vague allocations. Many of the transfers listed in the budget, such as those for cost allocation adjustments and general administrative positions, lack specificity in how they directly address opioid abatement. For example, it's already talked about the $5 million backfill of TANF, the $2.5 million for extended foster care, the $665,000 for audiology equipment calibration, and $2 million to upgrade the Summit View Intake Center. While these are important initiatives, they do not directly address opioid remediation, which is the primary purpose of these funds. Number two, the high administrative costs. The funds allow for up to 8% of its budget to be used for administrative expenses. While this is within the legal limit.
Engel. Thank you so much for being here today and sharing your lived experience. But we are past the 2 minutes. If you can please submit the rest in writing, we would really appreciate having it.
All right, thank you very much.
Thank you. Next person. Seeing no one else in Las Vegas, we will go to the phone lines, please, AVH.
Thank you, Chair. If you would like to provide public comment, please press star 9 now to join the queue.
Caller, you may begin.
Hi, committee members. Are you able to hear me?
Sorry, we can hear you and you can begin. Thank you. You have 2 minutes.
Oh, perfect. All right. Well, thank you so much, committee members, for all your time, efforts, and energy for this whole opioid abatement and
I'm sorry, and if you could say, I apologize, if you could say your name and spell it for the record. Thank you.
Absolutely. Yeah. So my name is Farzad Kamyar, Farzadkamyar. I'm a physician specializing in psychiatry and addiction medicine and a current member of the Advisory Committee for Resilient Nevada, the ACRN. As you all know, over the past several years, amongst other duties, one of our charges has been to provide guidance toward use of the settlement dollars available through the Fund for a Resilient Nevada, the FRN. These were established by Senate Bill 390, codified in Nevada revised statute. And just to sort of hone in, apologies for being repetitive on this, but we conducted the statewide needs assessment to really best guide the distribution of funds which are required per the NRS There's 14 sort of guiding statements in regards to that. Further, as you all know, then there's sort of 6 special populations that have been deemed priority populations. I'm really just trying to nail the fact that I hope we are as stringent with our budgetary sort of line items and transferring funds or funding programs as we are at the ACRN, FRN level for programs that have applied to NOFO. Just as an example, at High Risk Pregnancy Center, we have a program called the Mother Program. It's the only program in the entire state that uses an evidence-based care delivery model, combining high-risk obstetric care, mental health, and substance use treatment for specifically pregnant and postpartum individuals with opioid use disorder. We, to date, have not been approved for ACRN, FRN funds. We fulfill 7 of the 14 targets and 5 of the 6 priority populations, but we don't qualify. So I'm hoping that in all efforts going forward, those same stringent sort of requirements are held. Thank you so much for your time.
Thank you so much. We appreciate it. AVH, next caller.
Thank you, Chair. Those are all the callers that we have to provide public comment today.
Thank you so much. And with that, we will close public comment. And again, I want to thank you all and thank our members. We know this is one of the most important issues that impacts all of Nevadans. And this is my first ever subcommittee meeting. So thank you, everyone. And with that, our meeting is adjourned.